This is the EMS Research Vlog and Podcast, where we talk about the research-related issues that matter to those who work or study in the area of emergency medical services. Your host is Bram Duffee, who is a paramedic and communications professor.
Today, we're talking about when CPR is used in cases of severe hemorrhagic shock. So we ask ourselves today, can it help or could it inadvertently hinder recovery? So to help us explore this, we're discussing a recent study that was put out called Effective Cardiopulmonary Resuscitation on Perfusion in a Pig Model of Severe Hemorrhagic Shock. And this fascinating research article looks at how CPR impacts tissue perfusion and oxygenation during severe blood loss. The findings could shape the future guidelines for managing traumatic cardiac arrest. Even more exciting, today we have a lead researcher of the study, Dr. Patrick Greiffenstein, who is joining us to offer some of his insights. And so before we bring on Dr. Greiffenstein, we want to think about all the things that happened in this study. So from a medical researcher's perspective, this study addresses a significant gap in trauma care protocols. CPR is a cornerstone of resuscitation and cardiac arrest, right? But application in trauma-induced PEA has not really been rigorously evaluated there. And so that kind of validation is important. And PEA means pulseless electrical activity. It's when it looks like there's a heartbeat on the monitor, but there's no pulse because the blood pressure is not strong enough or you don't have enough. So this trauma PEA is a state where the heart shows the electrical activity, but there's no palpable pulse. And usually we're going to say in these cases of trauma that blood loss is the reason. So unlike medical cardiac arrest, where the heart stops because of intrinsic issues, this trauma PEA is fundamentally a low flow state. And that's when we're talking about hypovolemia, this insufficient blood volume. The American Heart Association's guidelines broadly recommend CPR for all pulseless patients, but emerging evidence suggests that this one-size-fits-all approach may not be appropriate for trauma cases. And so this study builds on prior animal research indicating that CPR might not only fail to help, but could actively worsen outcomes in hemorrhagic shock. So the primary goal of the study was to determine how CPR affects tissue perfusion, which is the delivery of oxygen and nutrients to the tissues, right? And brain and skin are the key aspects that were asked to look at during this hemorrhagic shock period. And the researchers hypothesized that CPR might not improve and could maybe even impair. So let's talk about what happened. The study used a pig model, which is common choice in medical research because of its similarity to humans. And the researchers removed blood from an anesthetized pig, so a pig that was put down like for surgery, and they did bloodletting basically until their MAP, which is the mean arterial pressure, dropped below 30. And this was done to simulate a state of severe hemorrhagic shock. And that's what happens when people lose a lot of blood. So what is this MAP? Well, the mean arterial pressure is the pressure of the average blood pressure in a person's arteries during one heartbeat cycle. So during the cycle, it's the critical number because it tells how well blood flow is flowing to vital organs like brain, heart, kidneys. So a normal MAP would usually be between 70 to 100. And if a MAP is below 60, organs may not get enough blood and oxygen, and that can lead to organ failure. So in this study, that's why they dropped the MAP to 30, knowing that that's dangerously low and would help represent a life-threatening state. And so what happened is that there was a CPR group and then a no CPR group. So one set of pigs received automatic CPR, like the chest compressions delivered by the machine. And then the no CPR group did not get the code and were just left untreated during that shock phase. And there was a randomization to that. And so we doing that ensures that the two groups are as similar as possible at the start of the experiment. And this way, any differences in the outcomes can be attributed to the treatment, which is CPR or no CPR, instead of just other factors. And so what happened was that after 10 minutes of this shock state, the researchers began resuscitation. They used the process called autotransfusion, where the blood that had been removed earlier was returned to the pigs. And so the goal was to raise their MAP back up to a safer level, so above 60. And the reason that they did this auto transfusion is because in real life trauma care, doctors often use blood transfusion to replace lost blood, helps restore circulation. So in this study, researchers used the pig's own blood to mimic this process. And so by raising the MAP above 60, they were able to ensure that the organs were getting enough blood flow once again. And so what happened is that throughout the experiment, the researchers monitored how well oxygenation was reaching the pig's tissues. And they focused on two issues, like we said. One is the brain oxygenation, to see if the brain was getting enough blood flow and oxygen. And the other was skin oxygenation. And by doing that, we checked the overall circulation. And the reason we look at oxygenation is because oxygenation is a direct indicator of how well the blood is delivering oxygen to the tissues. And if oxygen levels drop, it means that organs and tissues aren't getting what they need to function. And so by measuring this before and then during and after this shock period, researchers could see how CPR affected blood flow and oxygen delivery. And what they found were that there was not a big improvement in perfusion. So CPR did not enhance oxygenation in the brain or the skin during shock. In fact, skin perfusion was significantly lower in that CPR group during both the shock and recovery phases. Also, when we think about adverse effects, while CPR increased the systolic blood pressure, it also significantly reduced the diastolic blood pressure. So it increased the top number, but decreased the bottom number. And this is critical because the diastolic blood pressure is really essential for coronary and organ perfusion. The other thing is that this study saw an increase in the intracranial pressure wave amplitude. In other words, the pressure wave fluctuated much more than in the animals who did not receive CPR. And this suggests an abnormal flow, which could explain a decrease in the brain oxygenation, perfusion. So from a researcher's perspective, these findings can challenge the conventional wisdom of applying CPR universally in cardiac arrest scenarios. And the results could suggest also that in cases of hemorrhagic shock, that CPR might be doing something that diverts resources and attention from more effective interventions, like rapid blood transfusion or the surgical control of bleeding. Also, we know the worsening perfusion to vital organs is a problem, and that is something that could make the patient's condition even worse. So to learn more about all of this, we went to the source and we invited the lead researcher of the study. And I want to welcome Dr. Patrick Greiffenstein. Dr. Greiffenstein is a professor of clinical surgery at LSU New Orleans, and as well as the Trauma ICU Director at the Norman McSwain Spirit of Charity Trauma Center, which is the only level 1 trauma center in New Orleans. So, hey, I'd like to welcome you, Dr. Greiffenstein. We're really thrilled to have you here.
Great. Thank you very much. It's very exciting for me to be here.
Well, this is just a lot. Can you start by telling us a little bit about your background so our audience can get to know you better?
Yeah, sure. I trained at LSU New Orleans. I started in 2003, and halfway into my residency, I realized I really loved trauma. I loved the high-paced aspect of it, and I was also very frustrated by how patients would sometimes just not make it no matter what we did. And science, the science of that critical care, the science of resuscitation really appealed to me. So I took a couple of years off in the middle of residency to researched that a little bit here at LSU under the guise of Dr. Patricia Molina in the physiology lab. And I spent a couple of years hemorrhaging rats, getting them drunk, and looking at the effects of alcohol intoxication on hemorrhagic shock. And there's just so much to unpack there. Physiologically, the body is such an incredible work of machinery that when you alter anything, like induce alcohol intoxication, it can have profound downstream effects. So that's where my interest in science and bench work really came about. And then I finished residency, stayed here and did my fellowship here, and was lucky enough to get hired here. And over the course of the last decade or so that I've been here, really wanted to go back to the lab and study some of these questions. There are just some clinical questions that we cannot answer. We have to bring it to the lab. So a few years ago, that's what I did.
So what inspired you to think, gosh, maybe we just don't treat these people and watch them?
Well,
and like there's all this stuff about chemical codes and all this stuff about not doing adequate good CPR, and you were in a different camp altogether. So what inspired this?
Well, we've always kind of questioned CPR in these patients. It is challenging enough to have to deal with a patient who's crashing or dying without introducing a line of people taking turns to do CPR, and the bodies are bouncing on the bed, and you're trying to get lines and tubes, and blood is everywhere. Just the chaos seemed to be augmented by this addition of CPR. And then a few years ago, maybe 10, 15 years ago, we started doing ultrasounds in the emergency room on all these folks. And we realized that the trauma PEA, which is pulseless electrical activity, wasn't quite what the cardiologist had intended the definition to be. For a cardiologist, a PEA is a heart that's like really not effectively beating, not really squeezing, but you have an electrical rhythm. What we were seeing was not that at all. When we put the ultrasound on these folks who were in trauma PEA, the heart was banging away. So you didn't have a pulse, but we still had a strong contraction effect, hypercontractility, the ejection fraction of 80, 90, 100%. Every squeeze was squeezing out every drop of blood with every beat. So it didn't make sense to add CPR to it. And then I had a fellow came in, one of our fellows a few years ago, Alex Cavalier. He's now a trauma surgeon at Knoxville. He's my collaborator in all of this. He inspired all of this. He said, back when I was a resident, one of our staff was investigating this, and again, they realized that this wasn't really effective. And I looked at the literature, and sure enough, there really isn't any substantial evidence, scientific, clinical, that suggests that we should be doing CPR in these severely hypovolemic patients. And with that in mind, I had one patient come in a few years ago, maybe 6 years ago now, who young 22-year-old man who was stabbed in the arm and bled out at home. Police arrived, EMS arrived. They put a tourniquet on his arm, and they started CPR. He didn't have a pulse. Now, they transported him 45 minutes to the trauma center, which was breaking all kinds of protocols because, the right now the guidelines suggest if you're down for 15 minutes, if your anticipated transport time is greater than 15 minutes, you should terminate resuscitation. And thankfully, the EMS crew ignored that guideline, brought him in anyway. So they bring him in, and we get him on in the trauma bay. We stop CPR just to check his heart. And sure enough, he's in PEA, pulseless electrical activity, if you will. Heart is EKG is banging away at 130, 140 beats per minute. He doesn't have a pulse, but on ultrasound, that heart is squeezing. So that heart was squeezing as hard as it could. It didn't make sense to go back to do CPR. So I said, look, we're going to just get blood into this kid, get an airway in him, and let's just focus on resuscitation and not do any more CPR. Everybody was on board. We did that. And within 10 minutes, we got a pulse back. We brought this kid upstairs, repaired his brachial artery. He remained stable, and he went home 3 weeks later, wide awake.
Okay, so let me ask this then. How can someone go without blood in their body for that long and still have the ability to think and walk and talk like a normal person, because this is something that doesn't make sense,
Well,
right?
it's
I
a
mean, we're
very
talking about this is this is extraordinary.
you bring up a very good point. We are assuming that there's not enough blood to perfuse organs just because we can't feel it. Now you're saying that we've always assumed is that our digits were the most important sensory organ in a room. Like the most important tool in any resuscitation room is our fingertips, and I'm challenging that notion. What we're saying is that if we can't feel a pulse, the heart isn't beating, and that's not true. That is absolutely not true. The ultrasound shows a heart that's really effectively beating. So this guy is a young kid. He's got a big, healthy heart, and that heart is doing everything it can to maintain blood, as little blood as there is in the system, maintain just enough perfusion to all the organs to keep this kid alive. And so the heart was doing what it needed to do. It had just enough blood left in the system to maintain proper cerebral oxygenation, or at least minimal cerebral oxygenation and perfusion. And we just kind of honored it. We just supported it, gave it what it needed as quickly as we could, and recognized that bouncing on it any further wasn't going to help.
Yeah. I'm just thinking about all of this that has gone into what has brought us to the understanding of the correlation between the MAP being high enough to give us perfusion, because it looks like that maybe we have to rethink that, especially when we can't do readings anymore, right? So when there is no MAP to evaluate, now we're saying, oh, well, maybe we can get some enough perfusion. So, because I just imagined, from my perspective, I learned what I learned, and I thought, well, there's nothing going to the kidneys right now, there's nothing going to liver right now, and so we've been doing CPR for 45 minutes, and there's no blood left, and so that's what what am I thinking? And so it's really exciting to see this, because it's like an extreme consideration that we might be doing a different task, just kind of like a cold water drowning, like just a total extreme difference. So I have lots of questions for you, but can you just tell us more about the study and what things you found that were interesting that came out of it?
Yeah, so as you mentioned, there were several studies in the past that were animal studies that looked at this question, but all of them had looked at the sort of upstream aspects of it, the hemodynamics of it. I was interested in looking at what happens downstream, what happens in the organs, are they being perfused or not? And so we used an intracranial probe that we inserted into the brain that measured both pressure and oxygenation. And then we did the same for topical oxygen pressure in the skin. And I was expecting to see probably just equivocation. So I was expecting to see more or less the same on both sides, because as you mentioned, systolic is improved, diastolic is lower, but MAP, mean arterial pressure, is the same if you do CPR or not. And I was kind of taken aback when we realized that perfusion to the organs appeared to be worse in the group that got CPR. And I think the answer is in what we found in the cerebral probe. And the cerebral probe measured oxygen and pressure, but it also measured the amplitude of the pressure wave. And we saw that the amplitude of that pressure wave was 3 times higher in the CPR group. In other words, the pressure fluctuated tremendously when those animals got CPR. Speaking to a colleague of mine who's a former petrochemical engineer who studied fluid dynamics, he said that makes sense, because if you have a very, very low flow state, low pressure system, and you introduce this sort of high, low sort of fluctuation, what you end up with is potentially a disruption of the normal forward laminar flow. So blood, instead of flowing in one direction, maybe it's slower than it should be, maybe it's lower pressure than it should be, but at least it's flowing in one direction. If you introduce this high-low pressure variation, what you could be doing is inducing a sort of an oscillation and or turbulence in the system. And we all know that turbulence in flow can really impair efficiency. So it may not be delivering the oxygen to the tissues because of this disrupted flow.
Wow. What's cool about this is that more and more EMS agencies are getting access to be able to evaluate um, evaluate these problems because we have tools in the field now, so having the ability to do a field ultrasound is maybe 3 or 4%, but knowing things like this, that your study is showing, hey, if you can see the heartbeat, then we have to have other considerations. That makes it exciting because it's like we have this tool that is even more valuable.
Absolutely. No, that you hit on a really important point. You know, we we have a branch point right now in terms of care of these patients, where if we feel a pulse, we go in one direction. If we don't feel a pulse, we don't go in we go in the other direction. And we're relying on a very insensitive organ, which is our fingertip. What if we improved the sensitivity of our tool with an ultrasound? What if we looked at the heart directly to see what it's doing instead of relying just on our fingertips and a carotid pulse, which varies from person to person. It varies from maybe the body habitus of the patient can affect things. The sensitivity, you're asking for a EMS provider on the side of the road
Yeah.
to under, I mean, different circumstances. So I think that if we can improve the tool, have a much more sensitive tool at the scene to determine whether or not the patient needs CPR. I think that's key. And more agencies around the country, around the world are suggesting that. The American College of Surgeons Committee on Trauma, as well as with the National Association of EMS Physicians and American College of Emergency Physicians, just put out a consensus statement last month, 2 months ago, suggesting that EMS crews should perform life-saving interventions and only CPR if that was indicated. In other words, CPR should not be the first thing you do in a pulseless trauma victim. Stop the blood loss, give them blood, and introduce an ultrasound that will help you determine what the next best step is.
So for someone like myself who does not have a background in ultrasound, and I'm sure there's lots of other paramedics out there, and we do doctor tasks sometimes. This is obviously a doctor task. How long is that? How difficult is it for someone like myself at a technician level to be able how difficult is it to teach a technician to be proficient at this?
Oh man, you've hit the mother load. That is such a loaded question because you assume that you have to have this incredible background, and this is a very, very accessible technical tool. Number one, it's being done in multiple organizations around the country. My collaborator, Dr. David Rayburn, is one of the directors at New Orleans EMS. He started training his paramedics to do field ultrasounds just a few months ago, maybe early last year, and they're picking it up and showing proficiency with it very, very quickly. There's a researcher named John Mitchell out of Michigan. He's an anesthesiologist. He's started an entire program to train Navy SEAL medics in performing this. And so now the Navy SEAL medics on these teams are going out there with handheld ultrasonography because they recognize how vital it is to have this information in the field under those circumstances. They can't afford to waste resources in those austere environments. So they have to know what to do, and what they're doing is the right thing to do. And what he's shown is in a 4-day course, he can take SEAL medics with virtually zero prior medical training before they join the teams to near mastery, to almost being as good as a trained cardiologist in performing these simple tasks. And what we're talking about we're not talking about measuring the ejection fraction of, through a vessel or the degree of regurgitation. We're talking about very simple stuff. Put the probe on the heart, and is it squeezing like normal or is it not? That's it. That is your branch point. If you see a beating heart, you stop and you start doing perfusion. And that's even before we start getting into all of the new technology that's out there the current ultrasound companies are now putting out probes that are intelligent, that have AI capabilities. Not only AI capabilities that will prompt the user to adjust their hand in a particular way, but also will help interpret what they're actually looking at. So the technology is expanding, is growing exponentially. It is well within reach that we're going to have the capacity not only to train providers in the field, but we're eventually going to have an ultrasound device that's entirely portable that you can put on a patient's chest that will give you exactly what's going on with the patient's heart and what needs to be done next, just like we have the automatic IED devices.
So it does sound pretty easy considering like we're just checking to see if there's movement or not. So how about detecting bleeds for a technician level, abdominal bleeds or something like that? How is that also fairly easy to train?
Yes, it's something we teach our junior residents now in trauma. They get trained in using ultrasound, the FAST exam, the focused abdominal sonography for trauma protocol, which is looking in the abdomen and under the xiphoid to look at the heart, and you're looking for sources of blood loss. So again, you're only looking at whether or not there's fluid where it doesn't belong. It is entirely within reach, completely within the capacity of an EMS or paramedic.
So what we're talking about here seems to be a little bit more exciting than what I initially introduced with, because we're talking about probably for sure a major change that we need to be thinking about. And it's exciting to note that, we're able to move things further in this area. CPR is a really scary thing because our prognosis is bad. And, for so long, it seems like that we have just been doing the same old. And so I appreciate the investigatory stuff that you're doing, because I can directly see not only is this something that we can now consider, but we have tools in the field that will help us think this through. We do have blood products in the field. Now we have ultrasound in the field, so this is definitely pushing things forward. So do you have any advice for young researchers that are interested in this field, or any other thoughts that you'd like to share as we finish up?
Oh, absolutely. This is a huge, huge area. As you said, it opens up everything. We actually just finished the second round of animals. We're actually looking at the tissue perfusion itself to sort of confirm the findings of our first experiment. Hopefully that'll come out this year. But there's so much more to do with regards to who survives and who survives with function. Right now, our overall survival rate, if you have a traumatic out of hospital arrest, your survival rate is about 4%, but only one of those four patients, 1% out of those 4% is going to survive to make it out of the hospital awake. So our functional recovery and survival is very different. When you look at survival rates, you look at 4%. That's not survival in my book.
Agreed.
Survival to organ donation isn't survival, and I don't call that a victory for me. So I think that we have to examine why it is. What were the circumstances around that one individual in four who wakes up and makes it out of the hospital awake? And there's some exciting literature in the military. The UK military put out a study in 2011, 2 years in Helmand province in Afghanistan. They followed patients who underwent traumatic cardiac arrest. And in their series, they had an 8% survival rate. But more importantly, all of their survivors woke up. So why is that? What is the difference between somebody who wakes up and somebody who doesn't wake up? And I think that is an entirely unexplored aspect of this whole thing. And to me, helping people survive cardiac arrest is important. But I think we as a field owe it to them to do everything we can so that these folks actually survive with the possibility of functional recovery.
Absolutely. And these military cases, this is another advancement, because really you don't have an opportunity when you're a field medic, you don't have the opportunity to on the battlefield necessarily do the full chest compressions and everything, right? You sometimes might be in a position where all you can do is just drag a person to a safe position. And so knowing now that those extreme efforts that really tax the system, like you mentioned earlier, lining people up to do CPR, now to know that it just causes this turbulence within the system, and also knowing now that it is possible to have perfusion at these unreadable map scores. I just appreciate you sharing this with us and being there for all of it.
Absolutely. Thank you very much. Thank you for having me.
Like many of you, I'm also an EMS instructor, so I know what it's like to have topics that are important to cover, but are not actually in your curriculum. So when it comes to EMS research, I want you to know that I've been joining EMS classes lately in a virtual kind of way. It's fun for me to meet your students and talk about EMS research, or even talk about how things are done differently where I am versus where you are. So if you're an EMS instructor like me and you want to give your students a flair of what EMS research is all about, just fill out the inquiry form on my website at professorbram.com. This is professorbram.com, and I'll be in touch. I want to also invite you to check out my latest book. I co-authored it with 4 Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis.
We've got to look at each individual patient as a human being who is in need. And we've got to know that when we're in need, we do look to others, no matter how self-reliant we are. If we are in a situation that we've never encountered before, that self-reliance begins to seek, is there anyone that can help me with this situation? I mean, you've used a pretty drastic example with the arm cut off, but I don't care how much skill you have. There's very few people who would be able to not say, "Oh my gosh, I need help," and then all of a sudden someone shows up
with a badge.
Yeah. And right. You think, well, maybe this is someone that can help. Well, you said that, and I said that, during the first hour of trauma, people are essentially in a state of what we now know is hypnosis state.
I want to invite you to check it out, because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of the properties found in hypnosis. The book works to change the way we approach and interact with any emergency patient who's in acute distress, and it can help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. Follow a link there below to find it, or you could get it almost anywhere books are sold. And if you contact me, I would be happy to mail you an autograph sticker designed to be put into the jacket cover.
Hi, I'm Will Chaplot from the International Pre-Hospital Medicine Institute. You might know about us because of the literature reviews that we post every month, free to review on our website at iphmi.com, and also published through GEMS Online Magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference, whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field, or what we should be doing in the field, or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here, and they're all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes and Noble, wherever you get your ebooks, for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials, relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon.
I'm doing a research project related to first responders who live in the United States, and I could use your help if you don't mind being interviewed over a video call. go to my website and fill out the form. It's at professorbram.com, professorbram.com. I just want to thank you for listening, and I look forward to sharing more insights with you in the next episode. If you enjoy EMS research, please tell your friends and like, share, and subscribe to help others get the message.